Lovely. Oh, there we go. Hey, before we get too embedded in maybe finishing the session at 5, I just wanted to make sure that John Gatwood got a round of applause, because I know he's too humble to come up and do it himself. John is, he probably wouldn't admit to this, but he's the mastermind and done the bulk of the work with putting today's event together. So thank you, John. No, really well done. To say that I'm feeling a little bit inadequate to open a session that has the likes of Andy Higgs and Tim Cook in it is probably a little bit of an understatement, so I'll do my best to do it justice. And I think the point of what I'm about to talk about for the next 15 minutes is to set the scene for what Andy and Tim's recordings, or hopefully Tim in person, will build on in terms of these guidelines, the prevention of unrecognised esophageal intubation. So I'm going to talk about 4 cases briefly today, and one of those happened here in Victoria, and 3 of them have been selected from the Puma website, which there's many more, but I've selected 3 for certain reasons. And the intent of presenting these cases, these very important stories, is not to criticise the clinicians involved by any degree. It's far from it. Rather, the intent of sharing these cases is to make sure that we can highlight and emphasise and foster an appreciation of just how we are all vulnerable to similar actions that I'm going to describe. Before getting started as well, I just want to express on behalf of the team the deepest sympathies to the families and friends and the patients that are involved in these tragic accidents. This is Ambulance Victoria. This is where I work as a MICA paramedic, or an intensive care paramedic. And around 2 years ago, we had 3 identified cases of esophageal intubation, and 2 of those went unrecognised for a prolonged period of time. I'm just going to present one of those today. So the case in question involved a patient who complained of chest pain, did a call for an ambulance immediately, went to lay down, family checked on them, and they were found to be unconscious. 000 was called, and an ambulance arrived within 10 minutes, which was an ALS team, so 2 ALS, Advanced Life Support paramedics, as well as a MICA single responder unit, a single intensive care paramedic. They found the patient to be in VF cardiac arrest, commenced resuscitation, and soon after they were joined by a MICA team, 2 more intensive care paramedics, who had 5 clinicians altogether at the scene. Standard cardiac arrest resuscitation commenced here, so we've got chest compressions, had defibrillation a few times, and manual ventilation was provided. Now, our first line approach here in Victoria is to insert an I-gel supraglottic airway for our cardiac arrest patients. This was unable to be achieved in this patient due to a strong mouth and jaw tone, trismus effectively, so the crew reverted to bag valve mask, which was effective. At around the 20-minute mark, it was the first intubation attempt, but due to that strong mouth and airway tone, they were unable to insert the laryngoscope. It was quickly abandoned. At this point, they were able to insert an I-gel though. There was a brief ROSC around this period, but that was quickly lost and the patient went back into cardiac arrest. At the 40-minute mark, we had our second intubation attempt. This time, the laryngoscope was able to be inserted to the patient's mouth, and with a video laryngoscope, as per the patient care record, a grade 2 grade of view was attained. Bougie was fed into the glottis and a tube railroad over. This is where we started a short video. This is the cabinography trace from that day. So as the crews intubated the patient, this is what they saw. End tidal comes back at 60. We've got large rectangular waveforms, inspiratory and expiratory phases. Clearly successful, I think we'd all agree. However, at this point, we have a flat trace that's lost. And if we fast forward a minute, it comes back and looks like this. Noticeably, the end tidal's dropped by 40 points, by 40 millimetres of mercury. And even though it's quite subtle over those first 8 breaths, we now see that end tidal starts to decrease on every ventilation. Crews recognised that there was a significant change. They were acutely aware of it. They didn't know what caused it, but they had seen the changes in this end tidal CO2. So they started troubleshooting. We troubleshooted things such as length at lips. We checked the cuff integrity. The ETT tube was suctioned. There was an airway circuitry exchange. There was a nasogastric tube inserted. And there also was a colorimetric CO2 detector device, which had a purple to yellow change. And for those not familiar with that, a yellow on those devices indicates the end tidal for 15. Despite that, however, the trace continued to do what you see on the screen at this point. Clinical examination findings at this time showed that there was tube misting and chest rise and fall. But despite these findings, we still had a trace that was flat. Now, there was concerns from team members during this case. On 2 occasions, a team member said that this does not seem right and that we should remove the tube and return back to supraglottic airway. These were either not heard and definitely weren't acted on because the tube remained in situ and the trace remained flat. At some point, it was decided to insert a video laryngoscope back into the airway and re-inspect where the tube was positioned. And what they found was that there was gastric contents around the tube and it was placed in the esophagus. As they removed the tube and put it back into the trachea, they removed the tube and they inserted a supraglottic airway, and this is what they got. An end tidal comes back at 80 with normal capnography waveforms. You can only imagine what they were feeling at this point. You'd like to think maybe it was a sense of relief that they figured out what the problem was, but most likely it was a term that was used earlier in the day, a sense of dread of what has just happened, how long was the tube in the esophagus, and how long has this patient been without oxygen. And in this case, it was just over 15 minutes. So resuscitation continued after this point. Unfortunately, the patient didn't respond and they died at scene. This case was internally reviewed, obviously, and there were multiple contributing factors that were leading to the errors that we've just seen. First and foremost, this was a resuscitation of a critically ill, unwell patient, which always carries a degree of stress. Also complicating this resuscitation was the strong airway tone I mentioned during the case, as well as the degree of SIPREC, or CPR-induced consciousness. So it wasn't a straightforward resuscitation. The patient also had a large body habitus. Human factors. Human factors are embedded in all airway crises, and this is no exception here. There was stress, as already mentioned. Team dynamics were a bit dysfunctional. And fatigue was an issue here. And it may come as a shock, but maybe it doesn't to the audience here, that the paramedic who intubated this patient was into their 16th hour of a shift. 16 hours. Other things that accompanied those human factors were cognitive biases of anchoring to those first few capnography waveforms at the expense or at the exclusion of all the other information that came afterwards, as well as confirmation bias, things like tube misting, chest rise and fall, that CO2 detection change, that all suggested that, to the crews anyway, at that point in time, that they were successfully intubated the patient, and this was an equipment issue. And lastly, and perhaps most importantly for this case, at around the time that this incident occurred, there were several widespread, statewide, well-known issues with our capnography function that have failed, especially during the peri-intubation phase. At this point, we didn't know what was causing it. It was still under investigation, but the crews involved in this case would have been aware. Therefore, a deteriorating or a flat trace seen in the peri-intubation phase may have been attributed to an equipment issue at the expense of the most important cause of a flat trace, and that being, of course, esophageal intubation. So when putting this presentation together, I was asked to cover different disciplines, and I went onto the Puma website where they've got a litany of cases, very similar to what I've just described, and it struck me how many of those contributing factors I've just mentioned are present in different geographies and different disciplines and by different providers. In this case, from New Zealand, for instance, where there was a misattribution of the cause of a flat capnography trace to an equipment issue. This patient presented to the ED with two gunshot wounds to the back. An anaesthetist and an emergency physician intubated the patient, and based on the view that they saw on the video laryngoscope, they both agreed that it was successful. Despite this, however, they did not get CO2 return. As I mentioned, attributed to an equipment issue, new CO2 monitoring was brought into the room while the tube remained in situ. That too failed to return any CO2. Finally, a flexible bronchoscope was put down the tube, and they found that in the esophagus. Patient was re-intubated without complication, CO2 returned, SpO2 came up. Unfortunately, it came up 23 minutes after the initial tracheal intubation attempt. The patient went to the ICU for 15 days and died of a hypoxic brain injury. Or this case from Australia, where there was initial spurious CO2 detection and misleading examination findings that led to error. This was an elderly woman who presented with gastrointestinal bleeding and required an emergency gastroscopy. During the procedure, there were some complications, desaturation, a neuromuscular blockade was administered. The patient was decided to be intubated by the anaesthetic registrar. And following intubation, what was reported were large amplitude waveforms for the first 4 breaths. This was seen to indicate successful tracheal placement. However, with each ventilation, that CO2 went down and went flat. Patient coincidentally had a desaturation period into cardiac arrest. An emergency button was pushed. We had numerous clinicians arrive to assist, including nurses and anaesthetic consultants. They had 4 anaesthetic consultants, in fact, in this case. And the question was asked a couple of times, is the tube in the right spot? Which the anaesthetic register replied with, yes, we had CO2 return upon intubation, which deteriorated following loss of cardiac output. Clinical examination findings at this time from those other consultants who arrived found that there was air entry and lung auscultation as well as chest rise and fall. At some point, the tube was decided to be removed and they returned to face mask ventilation, and then the patient was subsequently intubated with good CO2 return and a rise in SpO2. Unfortunately, this came 15 minutes after the initial attempt, and the patient went to the ICU for 5 days and they died. And lastly, this case from the United States, where there was team members who knew that something wasn't right and that potentially the tube was in the wrong spot and had expressed those concerns to the intubator or to the team, but these weren't acted on, or they were resistant against in this case. So this patient was intubated in the ICU by an intensivist. After intubation, they deteriorated into cardiac arrest, the emergency button pushed, an anaesthetist arrives, sees that there's clear signs that the tube's not in the right place, expresses these to the intensivist. They're met with resistance and there's heated discussion that ensues. At some point, a check laryngoscopy is allowed to be performed. They see that the tube's in the esophagus, it's removed, successfully intubated after this point. Unfortunately, again, this patient died of a hypoxic brain injury. So Andy spoke about the Humar guidelines earlier today, and the term universal, which is embedded in their acronym, was mentioned. And normally it applies in the Humar guidelines in terms of their international consensus as well as their management principles. But I believe that this term is as applicable to these cases I've just mentioned and the overall problem of unrecognised esophageal intubation. Let me explain. So as we saw, this can happen despite geography or provider, whether they are a paramedic, an intensivist, an anaesthetist, etc. And whether that provider is a trainee or a consultant level. It happens regardless of location as well, both pre-hospital, in-hospital, and there's multiple levels in the hospital. It doesn't discriminate against patient types. I've mentioned 4 cases that involved adults of various ages, but there's also paediatrics as well as infants in cases that are covered on the Humar website. Also doesn't discriminate against whether that patient's critically ill, well, fasted or unfasted. And it happens regardless of indication or urgency or complexity, happening in both routine cases, Lane Bromley, as well as complex cases. It is truly a universal problem. So to conclude, and before I hand over the stage to Andy, I just want to circle back to a term that was used in the opening of this presentation, and that's vulnerable, which has its Latin roots in the word vulnus, to mean to wound. And I want to say that we are all vulnerable to an unrecognised esophageal intubation. None of us are immune to having this happen to us during our practice. I'd also like to say that despite a lot of the efforts that have happened over the years, this continues to be a problem. So it's not a problem of a single discipline or a single geography or a single provider. It is truly a universal problem. And when approaching a solution to this problem, it is absolutely essential that we both acknowledge and recognise the vulnerabilities, our personal vulnerabilities, when it comes to these cases. Because by doing so, we can take that first important initial step of seeing how all of us are vulnerable to these things happening within our practice. And also, by doing so, we hope that we can, in the future, reduce the occurrence as well as the harm to our patients, the harms to their families and friends, the harms to our colleagues, and to wound the harms that can happen to ourselves in the long run after an event like this. And finishing on that thought, thank you for your attention, and I'll hand over the stage to Andy Heeks.